Hello everyone, thank you for the opportunity to present today. I'll be presenting the management and outcomes of GIT congenital anomalies in low, middle, and high income countries. It's a multicentric international prospective cohort study. I'm Dr. Mahmoud Fiky, an associate professor of pediatric surgery at Cairo University in Egypt. Just a bit of disclosure. I'm an associate professor of pediatric surgery. I'm also a clinical researcher with a degree from Harvard. I'm also affiliated with the IPEG and WFAPS, which are International Pediatric Surgery Societies. Also, I'm the RadCap admin, so I know a bit about registries. And I'm a collaborator for Dreams and Care and medical advisor for the board of CDHI International and a country lead for the Global Pediatric Surgery Study, which will be presenting today. To give you a quick facts about pediatric surgery, why is it important on congenital anomalies? In a 2015 Global Burden of Disease study reported that congenital anomalies have been the fifth leading cause of death in under 5-year-olds. It is the third of all infant deaths, more than 500,000 patient deaths, and of course most of them are from low and middle income countries, as opposed to only 3% from high income countries, which should be avoidable or at least less. Very little data is collected, as not all cases are diagnosed and not all reach healthcare facilities, which would make a bigger impact if more research is done to prevent these deaths. The most common surgical emergencies or pediatric or congenital anomalies that need a surgical intervention are the tracheoesophageal fistula and esophageal atresia, the congenital diaphragmatic hernia, the intestinal obstruction, and abdominal wall defects. Just a quick background about CDH, which we'll be talking about today, is that the incidence is about 1 in 2,000 or 5,000, depending on the area, geographical area. It's mostly Bogdalic type, not the Morgagni, which presents later in life. Congenital cardiac anomalies are present in more than between 10 to 25%, depending in the literature, and many genetic anomalies are present as well as part of a syndrome. This is what we mean by Bogdalic hernia or Morgagni hernia or hiatal hernia. The Bogdalic hernia is the most presenting in the neonatal age. The presentation is usually at birth with a respiratory distress. It can be diagnosed earlier during an ultrasound with the absence of gastric bubble, with the presence of abdominal defect contents in the thorax, or polyhydramnios, which again, there may be an intervention in the fetal age as a fetal endoscopic tracheal occlusion, which is again a bit of experimental, especially in our area. The presentation at birth is usually with a respiratory distress, cyanosis, retraction, scaphoid abdomen, or asymmetrical descended chest. There's a hemodynamic instability. If you do an X-ray, you'll find loops of intestine in the chest, and of course, this would lead us to resuscitation, which is very important for the prognosis. As a surgeon, I wanted to explain again how we approach these patients. We do a primary repair, or either through an open laparotomy to repair the defect and reduce all the contents into the abdomen, or through the thoracoscopic repair, which is more advanced now, and our center has been doing lots of these cases lately in conjunction with the IPEG, and I can say that we've had excellent results. Another thing to consider, which is the ECMO, which is present in many parts of the world, but again, it really helps in the prognosis of these cases. So the outcome in the literature is that it's very variable between 14 to 85% in high-income countries, to about 38% in middle-income countries, and there's no data about how the survival is in low-income countries, which will come to that. Many of these cases they have to live on with adhesive intestinal obstruction, with gastroesophageal reflux disease, and with pulmonary hypertension. There are lots of factors that have accounted in low survival literature, as the country income, as the ventilation, the availability of antenatal care, the ASS score, any unplanned interventions, availability of TPN, as well as other patient factors as the sepsis, the gestational age, the birth weight of the baby, and additional congenital anomalies. These all have contributed to low survival in the literature. In our situation in Egypt, we published a paper a year ago about how many cases were referred to our hospital, the Cairo University Pediatric Hospital. We've had over 50% of referrals from all over Cairo and about a third of referrals from the Delta. And if we didn't have any cases, we had to refer these cases to other hospitals. They've had a 40% mortality on follow-up. These cases would have been saved if they have reached a good center and have been diagnosed and operated upon. Which leads us to another big question, which is bridging the gap. Many cases, antenatal diagnosis and delivery close to pediatric surgery center is very important, so that these cases have the best care from a primary healthcare facility to a tertiary health facility, improving district level prognosis, resuscitation, which is very important, and timely safe transfer of these cases. And again, preoperative care at the tertiary level as regards to the surgical safety checklist, IV access, TPN, and ventilation. All these are very required to improve the outcome of these babies and how they can survive on the long run, especially in the low income and middle income countries, as in Egypt and in our region. And the most important is collaborative research. Collaborative research has proven to be the only way that we can bridge this gap and how we can reach, how we can make more babies survive and how we can improve our outcomes. And this is part of why I joined such a collaborative and why I'm really a great advocate of CDHI. So there are many pediatric surgery collaborations, and especially in CDHI and CDH. You can see that the DREAMS project and the global PaedSurg have been the biggest advocates of CDH, but there are many other collaborative research groups that are working on to bring on more surgeons and more multidisciplinary teams to how we can improve the outcomes of these babies. There's lots of clinical trial registries. I can talk about the DREAMS project, which I'm part of, which was launched by Columbia University in New York. They're dealing with probably the more of a genetic side of the disease, but again with surgical outcomes, and they've had thousands of patients until now. And we've had the CDH study group based in Texas. They've launched over 25 years ago with over 90 centers collaborating from over 18 countries and over 11,000 patients. And I know today many from the DREAMS project and from the CDH study group will be talking today, and I can really congratulate them on the great work done all over these years. But today we'll be talking about the Global PaedSurg study, which was launched in 2018. It's a research study about the congenital anomalies, particularly from low and middle and high income countries. The primary outcome was all-cause in-hospital mortality, with secondary outcome postoperative complications of these babies. The study over about 2 years, we've had about 2,000 collaborators from over 100 countries. We've had over 500 hospitals and about 4,000 patients. The study was designed by the genius Dr. Naomi Wright. Dr. Naomi Wright is based in King's College in London. She's had lots of work in charity and working in Africa and working with surgeons from around the world. She's been working with the GIGS group, and I've been honored to work with her. The study was funded by the Wellcome Trust and the King's College Health Partners. So the aim of the study was to address the current scarcity of research on congenital anomalies, particularly in low and middle income countries. Being from Egypt and from Africa, I can really speak about how there's scarcity of data and how there's no actual research done about any of these congenital anomalies. It was the first large series in this region and all over the world, and it was geographically comprehensive to include as many multi-centers as many centers in this study from different cohorts from around the globe. It was also designed to identify many factors affecting the outcome of congenital anomalies, whether these are tracheoesophageal fistulas, whether CDH, whether neonatal intestinal obstruction, and to create guidelines and advocacy efforts for global health prioritization and global surgery outcomes studies. It also enhances research capacity among collaborators and combines the huge disparity in research outputs, dealing with global registries, dealing with surgical outcomes, and dealing with different language barriers and different surgery and research guidelines. And lastly, it's to form a global pediatric surgery research collaboration to enable future research and intervention studies aimed at improving the outcomes of these poor babies, which, as I've talked earlier, that a lot we lose just because there's no collaboration and no actual data. So we registered the study at clinicaltrials.gov. The study was following STROBE guidelines. The data was collected using REDCap, which is an amazing tool to create collaborative research across the globe and for validation and for publication later. Statistical analysis was performed on all the cases. We've had prospective data collection from over 7 congenital anomalies. Over a 1-month period between over 2 years, we've had about 1,400 collaborators, 264 hospitals, over 74 countries in 12 languages. Even the protocols were printed and distributed over many languages. The primary outcome mechanism was all-cause in-hospital mortality, and statistical data was analyzed using multi-level multivariate analysis. We've had about 3,849 patients from over the globe. We've had about 4,000 conditions recorded. We've had about 264 hospitals and from over 34 countries. You can see the outcomes listed here, that gastroschisis, the discrepancy between the high, middle, and high-income countries, with about 90% mortality in low-income countries and 32% in middle-income countries, which again may be avoidable if just following the guideline or more research is done or collaborative surgical training is advocated. I mean, there are many options that a report for our conclusion from a study like this can help to really change the lives of these kids. For severe atresia, again, the huge disparity between high, middle, and income countries, with about 85% mortality in low-income countries and 30% in middle-income countries, which may be avoidable with just creating multidisciplinary teams between the pediatricians, neonatologists, antenatal care, healthcare providers, with WHO guidelines. I mean, the sky's the limit if we try to create a global alliance on how can we reduce these mortalities. And as we come to CDH, actually, there are no actual data from low-income countries. The data is still very vague, and we're trying to improve how can we present and how can we analyze and focus on these cases so we can know actually how exactly the numbers flow in high-income countries. And the data will be published from the study soon about exact numbers of mortalities in CDH cases in high, middle, and low-income countries in our study. But again, there's a huge disparity, obvious, double the mortality in middle-income countries and from high-income countries. And this goes on and on in other congenital anomalies that we have studied, as in standard atresia, the anorectal malformation, Hirschsprung's disease, and exomphalos, which again, many babies would have common or more than one pathology at the same time. The high mortality was attributed to many factors. The first would be the country income category, which was highly significant, that the low-income countries to high-income countries, there was about a 2.5 hazard ratio of having the mortality. Ventilation was needed but unavailable, was again a major factor in contributing to the high mortality. The ASA score, the anesthesia surgical score, again, it's what contributed to how the higher mortality in these babies. Receiving a blood transfusion was an ominous sign that this baby would have a higher mortality than other kids. Receiving ventilation was a higher mortality prognostic factor again. Having a further unplanned intervention, like a complication from the surgery or from the transfer or from the baby itself, was again adding another hazard to the baby. Having a no surgical safety list was another hazard factor, and which was quite unavoidable if these hospitals or these trainees have had adequate surgical training or at least following some guidelines or WHO guidelines. And having TPN available, but it was unavailable, was again a major prognostic factor, especially in some obstruction and CDH cases, which require a longer ventilation and NPO time. Dilated sepsis at presentation, which is again was a major factor, especially in low-income countries, with the defective diagnosis and very low antenatal care. And having additional anomaly, although it's quite cited in the literature, but again in our study has shown to be the least prognostic factor to cause to a higher mortality, as all the previous factors have contributed more to higher mortality in all cases. If you see the other way around, having a lower mortality contributed was having an induced vaginal delivery, which contributed to a lower mortality in these cases. Receiving TPN contributed to a lower mortality. Having a PICC line inserted caused a lower mortality in these cases, of course. Having a percutaneous central line, having cesarean section elective, high presenting weight contributed to lower mortality, which is a given. Higher gestational age, of course. So in conclusion, there's a significant disparity in mortality that exists for common GIT congenital anomalies globally, and a rapid action is required through a coalition of global stakeholders to address this through an equity of timely access to quality neonatal surgical care. And I can't stress on how bridging the gap and working together can really make this happen through collaborative research. The focus should be on antenatal diagnosis and delivery at the Pediatric Surgical Center if a case is suspected to have a congenital anomaly that requires an expertise to repair at birth, and or at a tertiary healthcare center. Improving district level diagnosis, resuscitation, and timely safe transfer to a healthcare facility or again to a pediatric surgery center is quite important to save this baby, as the trainees have the adequate training, education, and clinical expertise to save them. Perioperative care at the tertiary level, including surgical safety checklist, IV access, TPN, and ventilation. Having multidisciplinary teams is not as important at the clinical level, but again at the research level and before, so we can improve the outcomes, train our surgical trainees on how to deal with these cases, and how we can tell our paramedics, our nurses, our TPN, our nutritionists, our pharmacists, how we can all work together to improve the perioperative care of these babies, so that we improve the outcomes on the long run, especially in middle and low income countries, which again might be a given in high income countries, but in this region we still have a lot to work on to improve these outcomes. I want to thank all the team members from the Global Pediatric Surgery Research Collaboration, Dr. Naomi Wright, and to the Wellcome Trust and all involved at the King's Centre for Global Health and Health Partnerships at the King's College in London, United Kingdom. I was honored to work on this research project and hopefully to work on more coming in the coming period. I want to thank you all for having me today. I'm Dr. Mahmaud Fiky from Cairo University, Pediatric Surgery Department. I'll be available for the Q&A at, I think it's at 5 p.m. in case anyone has any questions or wants any clearance about the study. The study should be published soon enough, and once it's published, I'll be happy to send it to CDHI so that everyone can know about the actual results of our study and great efforts that global pediatric surgeons from around the world have worked on for over a year now. Thank you so much, and see you later.